Thanks very much. Thank you very much for the introduction and for being invited to be here today, talking about genetic predisposition to hematological malignancies with a focus on myeloid malignancies. So I have nothing to disclose, basically. So this is the overview of my talk today. So I will start saying a few words about what inherited hematological malignancies are. So my talk will be more a general introduction to the field. That probably it will clarify some of the concepts that James has already introduced in his presentation. So just to simplify, for those that are not familiarized with what hematological malignancies are, so we here have normal hematopoiesis. So we can distinguish three types of hematological malignancies, leukemias, lymphomas, and multiple myeloma. So depending on the cell of origin that creates this cancer, that starts proliferating aberrantly, we will have the different types of hematological malignancies. So if they are progenitors, we have leukemias, myeloid leukemias, or lymphoblastic leukemias. So if the cancer rises from a B lymphocyte that goes into the germinal center and differentiates into the cells that will produce antibodies in response to an antigen, so we will have the lymphomas depending on the cell, the status of the cells that proliferate to originate the cancer, we will have the different types of lymphomas. And we have the multiple myeloma that arises from plasma cells. So all these entities, or the majority of these cases, are sporadic, but we have examples of familial aggregation in all these type of hematological malignancies. So we can distinguish 8 classes of inherited syndromes associated to the development of hematological disease. And these are the genes that have been described or associated to these entities to date. So we have bone marrow failure syndromes that are not neoplasms, but are hematological diseases with high risk of leukemia development. So we have also this familial ALL that has been not very well studied yet, but these genes had been associated to ALL so far. And as James has presented before, there are also these syndromes, like the Down syndrome, that also predisposed to leukemia, acute lymphoblastic leukemia development. Then we have examples of familial proliferative myeloid neoplasms, lymphomas, or multiple myeloma. But what has been published so far is just some individual pedigrees, and these genes have been identified. Then we have cancer predisposition syndromes, like lymphomany syndrome, that obviously it also predisposes to hematological malignancies. So probably with the new technologies, and we are seeing this now applied at diagnosis, so we will be able to identify many other germline variants, identify new genes predisposing to these diseases. But so far, the best studied entity is familial myeloid malignancies, so familial myelodysplastic syndrome and acute myeloid leukemia. That is indeed included as a separate entity in the WHO classification of myeloid neoplasms. So that would be the focus of my talk today. So I will start talking about the non-predisposing genes. So as I said, MDS, AML, so myelodysplastic syndrome, acute myeloid leukemia are mainly sporadic diseases, but the familial cases may represent between 5 to 10% of these cases. It's probably more 10% since the discovery of DDX41, as the new predisposing gene, that basically germline variants in this gene are present in around 5% of all AMLs, So it's clearly the most recurrently mutated gene in familial MDS AML. So the pattern of inheritance in myeloid malignancies is autosomal dominant in general. So the age of onset is younger than sporadic disease, but again, we have DDX41 as a game changer because, as James has mentioned before, the age of onset of patients with DDX41 germline variants is close to the sporadic disease in comparison to the other most recurrent predisposing genes in acute myeloid leukemia. And as I said before, it represents a separate entity in the whole classification of myeloid neoplasms. But there are huge clinical challenges that James has already discussed in familial MDS-AML, because the recognition of these forms is very difficult, and the management of these patients very, very challenging. So the patients may not be aware of their own predisposition. There is a huge clinical heterogeneity intrafamilial and interfamilial. There is an absence of these diagnostic and clinical guidelines, although we are working on that. So we are putting together a lot of effort to make consensus guidelines for the management and the diagnosis of these patients. So then the penetrance of disease mutation, so the probability of developing the disease when you have these germline variants is very, very variable. So I will show you some examples later. Then we have this huge problem of the variants of unknown significance that may represent 1/3 of the germline variants that are identified at diagnosis. So as James mentioned, we can classify these germline variants using different algorithms. So we can classify them into pathogenic, likely pathogenic, benign or likely benign, or variants of unknown significance. So what can we do with these VUS germline? Should we report them? So I can tell you what we do in the UK. So our criteria is only hot or warm germline variants with additional evidence to change the classification into likely pathogenic after a discussion in a multidisciplinary team will be reported. But what happens if a VUS is incorrectly treated as benign? So obviously the diagnosis will be wrong, and there will be an inappropriate family management. But more importantly, there will be a potential donor-derived leukemia that James presented as well. So that's key, because as we all know, the only curative treatment for these patients is the bone marrow transplantation. So the best donor will be always a relative, but if the relative has the germline variant, the recipient will develop the disease again. There are lots of examples of these donor-derived leukemias. So that's really, really important to take in consideration. But if a VUS is incorrectly treated as pathogenic, then we are creating unnecessary anxiety to the family. But we may miss the opportunity of using a related donor for the bone marrow transplantation, and we may not find any other appropriate or matched donor for this patient. Then we have lots of family that, despite a clear family history, don't have any germline variant in the known genes. So then they may represent around 40% of these families. And obviously the management of these patients is really challenging, because we don't have anything to offer. So I will discuss this later, what we can do. So to simplify, I mean, there are many others that have been associated in some pedigrees, but we can't consider these genes as the very well-known genes associated with familial MDS-AML. So we can classify them depending on the level of gene disease association. So they can have high level, moderate level, or genes that are emerging now from basic research, or that are associated or mutated to other inherited hematological syndromes. So what about the function? So we have DNA binding proteins, we have telomere regulators, we have genes involved in inflammatory response, genes with completely different functions. I wanted to highlight a huge overlap between the genes associated to, or the genes that are the cause of inherited bone marrow failure syndromes, and the genes associated with familial MDS-AML, so it's higher than 73%. It's not surprising, but it's interesting to have in mind, because some of these bone marrow failure syndromes are recessive, or most of them, but we can find in heterozygosity the germline variants in the same genes, predisposing to MDS and AML. So then it's important to know to see that only 41% of these genes are also mutated in a sporadic disease. So the rest of the genes seems to be mutated only in the germline, not as somatic mutations. So this is interesting because it's if we identify new genes that are only mutated in the germline, that we can discover new mechanisms of leukemogenesis as well. So it's interesting from the biological perspective, but it also indicates that we should include all these genes in the diagnostic panels, even if we are testing tumor samples to detect new familial cases. So I would like to illustrate the huge heterogeneity and the complexity of the genetics of familial myeloid malignancies with 3 examples. So the first one is CBPA. So CBPA is a transcription factor very well known, involved in differentiation of myeloid progenitors, is mutated in both sporadic and familial cases. So it's somatic mutations, germline mutations. But it's quite particular, and it has something very interesting. So the germline mutations in more than 90% of the cases are always located in the N-terminal domain of the protein. But the patients, normally more than 90% as well, acquired a second CPPA mutation in the C-terminal domain of the protein. So the outcome of the familial cases, so the green line here, is much better than patients with sporadic mutations, so somatic mutations in CBPA and sporadic cases. It's even better than the patients with 2 somatic mutations in CBPA. And what is very interesting, and we discovered like a few years ago, is that the patients with germline CBPA mutations are cured from the disease after chemotherapy treatment. So they are completely cured, and then after a long period of remission, they relapse from a completely different clone. So it's a completely new leukemia episode, and we can know that because if we check which was the second CPPA mutation, the acquired CPPA mutation that we find at diagnosis, we see that it's completely different from the acquired CPPA mutation that we see in the relapse after this long period of remission. So the patients are cured. So there is no some cells that are left there that then proliferate again and create a relapse. No, but because the patient has already has still the germline variant in his cells, then he develops a new leukemia episode. And this is interesting because this doesn't happen for other predisposing genes in acute myeloid leukemia, such as the DX41. So we have these patients with the N-terminal germline mutations with a very high penetrance, so more than 95%. But we have some examples of patients where the germline variant is located in the C-terminal domain of the protein. So the penetrance in these cases is around 50%. So the management of so the probability of developing the disease is around 5%, and they require the acquisition of a second mutation in the N-terminal domain. So the management of patients with these C-terminal germline variants is really challenging, as you can imagine. So the second story is actually 2 stories regarding GATA2. GATA2 is a transcription factor as well, mutated in a sporadic disease, in familial disease, so in the germline somatic mutations, and is a very well-known player in hematopoiesis. So there are 2 stories interesting that I would like to present today. So the first one is this, it starts with this family where we have a germline missense variant passing through the different generations. So, but it's interesting because we have this 3rd generation here where all the carriers with this GATA2 missense variant are completely asymptomatic. Then we have this 4th generation here where all the carriers developed symptoms. So so we validated the presence of this germline variant, obviously, in the asymptomatic carriers, in the symptomatic carriers, but then we decided to sequence the RNA, so the cDNA. So what we observed is that in these 2 guys here, the asymptomatic carriers, we observed that they expressed both alleles of GATA2, the mutant and the wild type, whereas in this lady here, we only see the expression of the mutant allele. So we were very lucky because we had different samples at different time points of this lady here. So in years 1, 2, and 3, this lady developed cytopenia, so developed symptoms, but she recovered from her symptoms in years 4, 5, and 6. So we sequenced the cDNA. Again, in these time points, we observed the monoallelic expression. Only the mutant was expressed. She recovered the expression of the wild-type allele when she also recovered from her symptoms. And we aligned this with allelic-specific deposition of chromatin marks. So we observed that there was an enrichment in methylation in the wild-type, in the mutant, in the wild-type allele that was silenced in years 1 and 3, and no differences in when she had biallelic expression. Same for the H3K4-AME3 activatory mark that was enriched in the mutant allele when it was the only expressed, and no differences again when she had biallelic expression. So how can we picture that? No? So if we have 2 wild-type copies of GATA2, we will have a normal activity of GATA2, and we will have normal hematopoiesis. However, if we have a mutation that completely depletes the function of GATA2, loss of function mutation, then we will have haploinsufficiency. This will lead to cytopenia, and eventually, with the acquisition of secondary events, the patient may develop acute myeloid leukemia. So what happens in a situation like our family, where we have a mutation that retains partial activity of GATA2? So if we have the biallelic expression, the hematopoiesis will be normal. If we silence the wild-type allele, we will have cytopenia, eventually acute myeloid leukemia. And the interesting thing is that we can revert that if we reactivate the wild-type allele expression. So the second story regarding GATA2 is the presence of germline synonymous mutations in 8% of the cases with GATA2 deficiency syndrome. So that's very interesting, and I wanted to highlight because we are always discarding synonymous variants because they don't change the protein, the actual sequence of the protein. So we always consider that they don't have any impact on the gene or on the protein. No? However, this is a case where we have to consider also the synonymous mutations. So there is a particular hotspot synonymous germline GATA2 mutation that is this one. So I'm going to show you how it works. But there are other examples as well. So in this case, this hotspot mutation creates this acceptor site for splicing that, together with this donor site that was already there, removes this region here, creating a premature stop codon and a truncated protein. So just to have in mind that maybe we should start considering synonymous variants again. And then finally, I just wanted to mention DDX41 because it's important for the rest of my talk, but also because I think I just wanted to fix some concepts. Like, it was discovered in 2015, so very, very recently, but now is as I said before, is the germline DDX41 variants are the most common mutations predisposing to MDS-AML. It's important to highlight that 1/3 of these variants are VUS, so it's very challenging to work with these patients, as James has presented before, so we don't know exactly what to do. We need biomarkers, so pathogeneity or something to manage these patients with VUS DDX41 variants. And then it's interesting to mention that more than 80% of the patients acquire a DDX41 variant, but the relapse in DDX41 is from the same clone in this case, so differently from what we've seen for CBPA. So as I said before, only 60% germline variants in these genes only explain 60% of familial AML cases, so we still have these 40% of patients of unknown etiology. So we really need to identify these new disease genes, to identify mutation carriers, to include them on surveillance, to exclude them as bone marrow donors, to manage the risk. But it's interesting also from a biological perspective, to understand the leukemia biology, to understand the disease latency, the penetrance, the order by which mutations arise. And as I said before, if the genes are not mutated in sporadic disease, they are also giving us information about leukemogenic mechanisms. So we collected 87 families, MDS-AML families. So we, in collaboration with the West Midlands Regional Genetics Laboratories, we we created a sequencing panel specific for familial MDS-AML genes. So we looked at all the genes related today to MDS-AML, familial MDS-AML. So we characterized 57% of all these families, but we have these 43 remaining families where we perform whole exome sequencing to identify new genes. So we follow this criteria of filtering. So we looked at the BAF when we didn't have the germline material, so we only took variants with higher than 30% of BAF. We obviously only picked up genes that segregated with mutations that segregated with the disease when we had two members analyzed from the same family. Sometimes that was not possible, depending on the family. So we only picked up mutations with a very low frequency in GenoMat and exact databases, and predicted to be pathogenic in at least 2 out of 4 tools of functional annotation. And we only selected genes that were at least mutated in 2 of our families. So this came up with 130 germline variants in 52 candidate genes that are represented here. Still a lot of genes, just so we published this data, but we only wanted to also to follow other criteria to select the most relevant genes. So we cross-reference our list with previously published list of genes that could potentially be predisposing genes, and this allowed us to identify these 3 new genes. In particular, DNA H9 was very interesting because of the homogeneity of the clinical feature in our families, but also because they fitted quite well with Lucy Godley and Jane Cherpek published in another pedigree. So we also looked at if some of our genes were previously associated or were the responsible of rare hematological syndromes. We were very lucky because we had ADA, GP6, and so ADA, that was basically germline variants in ADA are responsible of this severe immunodeficiency. GP6, that is the gene responsible of this bleeding disorder, or SEC23B. And then the third criteria was just looking at the function of the gene, if it was relevant, and if it was present in mutated in a significant number of families. And in this case, DHX34 fitted both criteria, so the function was very interesting because this gene is another RNA helicase like DDX41, and it's also a key player of the nonsense-mediated decay pathway. We had 4 families with germline mutations in this gene, all of them in functional domains. So we decided to validate if they were actually loss of function mutations or not. So we had 2 readouts. So the DHX34 binds to UPF1 and induces the phosphorylation of UPF1. So we look at the binding. We observed that this binding to UPF1 was reduced for the 4 mutants. Same with the phosphorylation of UPF1. It was reduced for the 4 mutants as well. So we could confirm the loss of function nature of these mutants. But what else makes DHX34 one of our favorite new candidate genes is just because after our publication, this paper came out, and because DHX34 is not mutated in a sporadic disease, so there are no somatic mutations, but it exhibits alternative splicing in 1/3 of sporadic AML. So this paper looked at that and identified that 1/3 of sporadic AML patients show this splicing, so they have the inclusion of this cryptic exon with a premature stop codon, which leads to a decreased expression of the active protein. But also DHX34, so we published this paper last year, so we looked at the function of DHX34, and apart from being involved in the nonsense-mediated decay pathway, we also found that it's also involved in RNA splicing, so like DDX41, but moreover, we found that DHX34 interacts with DDX41. So then we performed following this pipeline that we published for to check the function of other genes. So we wanted to see which were the consequences of the silencing of DDX41 and DHX34 in human hematopoietic stem progenitor cells. So we silenced these two genes, and we performed a co-culture with a stroma layer of mesenchymal stem cells to mimic the bone marrow niche. And then we also performed a colony-forming unit assay. So that's very, very preliminary, but we've seen that both DDX41 and DHX34 silencing decrease the proliferation and decrease the number of colonies of HSPCs, in particular myeloid and erythroid colonies. And moreover, we have identified more than 50 patients with hematological malignancies and DHX34 germline variants in collaboration with many different hospitals in Europe. And now we are trying to look at whole genome sequencing data published to identify more DHX34 to describe the mutational landscape and the clinical features of these patients to better define what we are facing with DHX34 and if it should be included as a new predisposing gene. And so this is the summary. So basically, we validated our data, so they're overlapping with bone marrow failure syndrome genes. We identified genes associated to other rare hematological disease, but also predisposing to familial MDS-AML. But we also identified genes that were only mutated in familial MDS and AML. Just to finish, I would like to say a few words about consideration for genetic testing and counseling. So. The first thing that we have to have in mind is that we don't have anything to offer to these patients, so there is no prophylactic measure that we can take for the carriers, but the early identification of these mutation carriers, it allows proper anticipatory medical care, and that's very, very important. So we can identify familial cases through 3 different ways, so because the patients are aware of their own predisposition, the family history, because we identify some variants at high VAF in the diagnostic panels, or when we check for the donor, related donor for a transplantation, we looked at the predisposing genes. So it's in this case where we can say, oh, maybe we are facing a familial case. In any case, we have to validate this in a germline material. As James presented before, that's still a debate, which is the best germline material. So I'm not going to go into that because he explained it amazingly. So then we have the problem, so if we run with the germline material a panel specific for genes, of predisposing genes, we have the problem of the variant interpretation that I mentioned before, especially with the VUS. We are working on that, but we need functional studies. If the patient is positive, then we have the problem of this counseling. So we are performing clinical guidelines. We do know now that we need consortiums like as James presented. We need to consider each gene individually because we can't make guidelines that can work for all the genes together, so we have to be very aware of that. And then, if the patient has any mutation in this panel, so we have to include them in a research pipeline to identify new predisposing genes. So this is why we really need to work together to put all the families together to improve our tissue banks, because we need cells to do all the functional studies that I presented before. So we really need cells. We need to include the predisposing genes into the genetic testing panels to identify new genes and to improve the management of these patients. So, and that's all. So I would like to thank all my colleagues, collaborators, the funders, and obviously the patients and families, because without them that wouldn't be possible. Thank you very much for your attention.
Thank you very much, Anna, for a fantastic presentation and for keeping perfect timing. Actually, we are early, so this leaves us more time for questions. And to begin with, we have a couple of questions from the chat. And the first one is from Rosario Leite, who asks if there are familial cases with V617F mutation in JEC2.
In JEC2.
Yeah.
There are lots, but that's so there are, but it's not clear exactly what JEC2 does to induce acute myeloid leukemia or myelodysplastic syndrome. So, because JEC2 also predisposed to so many other cancers.
Yeah.
But yeah, obviously.
Sorry, JAK2, JAK2.
Yes.
So the
as well. James presented this as well. So yes, there are families, and in this case, it's much clearer. But there are not too many examples published. But yeah, there are some germline variants. Indeed, we have a couple of families with JAK2 germline variants.
Okay, thank you. And before we go on to the auditorium, I have another question from Dodukan Alkan. Would you suggest clinicians to evaluate DDX41 and DHX34 in children with hematological malignancies whose parents had common solid tumors such as lung or colon cancer?
I mean, DDX41 for familial, so the pattern, also the age of onset is quite late. So there is always a debate for when to check in children. So this is something that we are debating we have a working group to perform the consensus guidelines in the UK. And we are never recommending testing children for DDX41, for example. Never, because it could create anxiety for parents when it's not clear what will be the outcome.
That's very clear. Thank you very much. There is a question on the back right. Yeah, okay.
Thank you very much for this wonderful talk. I'm at the back there. I'm Berna Beeflo from the Erasmus University in Rotterdam, and involved in diagnosing predisposition for myeloid malignancies. Together with the hematology department, we carry that out. But what we are wondering and struggling with is the ICC guidelines that have recently come out, where they suggest to test familial relatives that have a solid tumor, and not direct relatives, but also some generations apart. What are your thoughts about that?
Yeah, I mean, I know that's because we had this discussion several times. So it's, I wouldn't do it, but I think it depends on the group. So it's difficult to give an advice for that, because you will find something probably, but then it will be really challenged how to manage then the family itself, because it's not clear what will happen if you identify some genes that may predispose to both solid cancer and leukemia, and it's not the same when you don't have anything to offer. Mm-hmm. Because it's apart from a surveillance, we in the UK, when it's a gene with a really high penetrance, we can offer one blood test a month and one bone marrow a year, but only if it's a highly penetrant. If it's not highly penetrant, it's difficult to put the patients on surveillance. So I think it creates more anxiety than anything. So I think the best approach will be including to make the panel with most of the genes included related to familial MDS AML, a diagnosis, and then in a multidisciplinary team making a decision about how to inform these variants. But yeah, it's difficult to give an advice, so just you can make your own decision. I've seen that each hospital basically follows its own criteria. This is why maybe consensus guideline that we are working on will give more something clearer for you.
Yeah, I'm really looking forward to that, because it's also very difficult, because some of the genes that are involved in that familial predisposition, they also predispose for breast cancer, etc. And so you run easily into secondary findings or unsolicited findings, so to say.
Yeah, in the UK we are very careful with the consent form, when we are because we have always like a specific box to tick or not, if you want to be informed about secondary findings, because obviously that's the risk when you are testing the germline, that you can find something else. And even if you were looking for something related to hematological malignancies, you can find something else, and you need to ask them if they want to know or not.
Okay, thank you. We have a question just in front of you.
Thank you. That was an excellent talk. In your 50-odd families with the DHX34 variants, is it a similar age of onset to DDX41?
No. And indeed, the spectrum of hematological malignancies is quite broad, because our 4 families, because we were restricted to MDS-AML families, all of our 4 families were MDS-AML. But then when we opened the spectrum and we asked all different laboratories and hospitals in Europe, they identified and they looked at all hematological malignancies. They found a really broad spectrum, like thrombocytopenias, MDS, CLL. So I think we need to, this is why we really need to understand the implications. But it's not, in terms of age of onset and phenotype, it's not similar to DDX41 so far.
Were you seeing pediatric cases?
No.
Okay.
No.
On the other side, there is a question. Yeah.
Thank you. Claire Turnbull, Institute of Cancer Research in London. So I'm a clinical geneticist, and I was just listening to both your and Hamish's talks, and it's not specific to hem-onc malignancy, but I think hem-onc inherited malignancy epitomizes this issue that we're dealing with such small numbers of families, and at the moment we're working with relatives in whom we find the familial mutation, and it's quite small numbers, and we do our best. But there's this sort of rumbling emergence in the background of doing this type of genetic testing at a population level. And we're doing screening, we're doing risk stratified screening, and we have no idea whether our screening test, whatever it is, annual bone marrows, monthly full blood counts, alter the outcome. And we have quite poor understanding of the natural history of pre-symptomatic disease, i.e., are we actually going to change outcomes by intervening early? And I guess it's a question also for Hamish, or if you have any thoughts, how can we design our studies and trials, and can we do trials that answer these questions while we're still sort of in control of the situation with our small numbers of familial ascertained cases before the dam breaches and we are testing for these types of genes on population level? That's more of an existential crisis than a question.
Yeah.
But any thoughts?
I agree. Maybe Hamish, you want to mention something about this? It's a bit, yeah. I mean, I can talk about hematological malignancies more than anything. So I think in hematological malignancies it's very difficult because the progression of the disease can be really fast. Yeah. So like months. Yeah. So there is nothing that one day you are fine and the day after you can't do anything for the patient. So sometimes this is the progression, but
presumably others are very indolent.
Good.
Yeah,
presumably
exactly.
You're picking up indolent disease as well, and some people jump early and transplant, and that's doing harm. Yeah. So
yeah, but you will never do a prophylactic transplantation, because that obviously the patient can die just because of the transplantation. So which is
I guess how early you
So I don't know. Any thoughts?
Yeah. So there is a question in front of you from.
Hello.
Hi.
I'm Leah from France. I was wondering, you talked about testing donors from the family, but what is your opinion about testing anonymous donor on the list? Have you ever encountered a situation where there is a leukemia on donor cells from an anonymous donor?
And non-related, you mean, no?
Yeah,
non-related.
Non-related one.
What they always checked, or at least as I'm aware of, they are always checked for the canonical predisposing genes. So I never seen published that, but it's probably possible. I never seen it published, but obviously, I mean, this may happen.
So you're saying that in England, every donor is tested?
Well, at least tested for the germline variants. Okay. So there is like a, but only for the genes that the very, very, very well-known genes. So probably, I do know that they are not testing for the 22. So obviously, some of them may be missed, but the ones that are highly penetrant are checked as a routine for any donor. Yeah.
Okay, thank you.
I do have a question myself for both Anne and Hamish. That was absolutely revealing. I'm quite amazed by DDX41. Right, so no chip association, super late onset, right? And quite specific is, if I understood correctly from Hamish's talk, pattern of mutation. So it seems to be you have a truncated hit in one allele, I presume, and then a secondary missense, right? Is the secondary missense a hotspot usually?
Yes. Hamish mentioned that.
So it's this late onset because it's way harder to get the 1 second hit during life.
Definitely, definitely. Right. So you really need the second allele. Indeed, one of the criteria is because of the problem with the VUS variants, so we don't know what to do with them. So the criteria that they are following in some of the hospitals in the UK, I was talking to the hematologist the other day, when they identify a VUS variant and they don't know what to do, they only inform the VUS variants in DDX41 if the patient has the second mutation. So they will never inform a VUS variant without the second DDX41 acquired. But in some cases, they have VUS with a second acquired, and then in this case, they are pretty sure that is a familial case or like inherited.
Right, so the odds of getting the secondary in a specific point what makes it a late onset.
Obviously, we can't know for sure, but it makes sense.
Okay, great, thank you.
Thank you. A very quick question from me. You mentioned that VUS might be wrongly treated as benign, and therefore relatives would be used for bone marrow transplantation. Do you mean all types of VUSs or just the hot VUSs? What is the attitude in the field for the hematological community?
So we have a project exactly working on that, trying to identify if there are different VUS. If there are some VUS that can be clearly classified as likely pathogenic, but we need biomarkers. So we need to understand first what this loss of function of DDX41 does from a functional perspective, and then identify biomarkers, and then identify the function, and if we are able to classify some of the VUS or into more pathogenic and some of the VUS that are clearly, or if some of the VUS are more prone to acquire this second DDX41 or not. So the good thing is that because now it's going to be included DDX41 in all the panels, so we will get more and more patients with DDX-GRLIME. So it will be, in the coming years, we will have a huge amount of patients that we can analyze and that we can include in our functional studies as well.
I think just a very quick last question, please.
Thank you very much. It's very disheartening to know that patients who have a potential donor, but the donor has a VUS, they can't probably receive a transplant from them because they'll still go on to develop the disease. So what is the alternate strategy in your opinion? Like, can we 3D bioprint a perfect bone marrow and give it to them? What are your thoughts?
So that's the main problem. So basically, in theory, all the VUS relatives, so all the relatives with the VUS should be discarded, no, in the ideal world, just to prevent the donor-derived leukemia. But it's very difficult sometimes to find a matched donor, unrelated donor for that patient. That should be the approach. I mean, looking for an unrelated donor. So this is why we really need to understand the VUS function to see if some of the VUS can actually be classified as benign, and then use that relative donor that would be the best and unique treatment in some cases, because that's the problem, that sometimes if you can't find, so obviously you can treat the patient with chemotherapy, and there are lots of studies coming from DDX41 because we are having more and more patients identified, and some of the coming studies are focused on how these patients respond to different treatments. So some combinations of treatments seem to work quite well for these patients, so obviously there are alternatives. But in terms of the transplantation, it's tricky, and this is why we need to know more about the actual function of these VUS.
Okay, thank you very much, and thank you to both speakers for an exciting educational session. We have learned about hematological cancer predisposition, and I think there are lots of questions unanswered, so there is room for research and finding the correct treatment and care for patients with these conditions. Thank you, Hamos and Anna. Yeah.